All right, we're recording. Go ahead.
Good morning, everyone. So as we discussed, this education session will be focusing on brain death or death by neurological criteria. I will jump from PowerPoint where there's just a few slides that concise quite well the process of declaration. And then also I'll show you the guidelines where there's just a few details that have been implemented in the recent guidelines of the American Academy of Neurology in 2023. And then in terms of documentation, I can show you in Epic that we have a template, a navigator for the declaration. And don't forget to do the discharge summary, so I can show you also what template to use. Since I opened two PowerPoint, I want to make sure that the correct one is displaying right now. Do you guys see ASN 2023 annual meeting? Charlotte, by any chance, can you confirm that you can see the PowerPoint that says ASN?
We can see it.
Okay, perfect. Great. So the only good slide about that was this one. I'll jump to this one. So establishing brain death is a process that is purely clinical, and we should only resort to ancillary testing when there's some part of your clinical exam that you are unsure of, or that the clinical exam, the element is not accessible in a valid way. So it's a process also that is clinical with one clinician, usually an attending. You cannot be a trainee. So even if the residents in neurosurgery and neurology have to learn, and you're welcome to do the process with me or other neuroclinicians in the ICU, you cannot be the one authoring the note and declaring the patient. You have to be an attending, but we'll go over that because the guidelines also went into a lot of details about the qualification of the people. But it's a clinical process. You as a clinician, as an attending, as a neurosurgeon, neurologist, or intensivist should feel comfortable going through the process. That starts with actually identifying the correct patient. You'll see me in the room always regrouping with the resident, the nurse of the patient, and making sure we enter the correct room, that we know exactly what happened to this patient. You cannot declare somebody if there's no cause for the coma. So you need to establish the etiology, it needs to be known, it needs to be a proximate cause that is irreversible with an acute a CNS event like a cardiac arrest or a severe traumatic subrac, and a large intraparenchymal hematoma, and basically there was subsequent herniation, and it is notoriously in the literature associated with a progression towards brain death, which is an irreversible loss of all neurological functions. So you look at the CAT scan, basically, you need to see on the CT that there was an injury that is compatible with the coma and the progression to brain death. Don't declare somebody just because of a coma not otherwise specified, especially if the circumstances were, let's say, he was found immobile in the back of the garden at home. Well, then that could be an organophosphate intoxication, or he was found at somebody else's place after a party next to a needle. Then obviously you need to check for UTOX and blood, also levels of many different toxins that are notoriously sometimes mimicking brain death. You can have a loss of all neurological functions because of a toxic or a drug on board. Then step 2 is the requisites need to be met, that your assessment, clinical exam of the patient will not be confounded by other things that can plunge you into a coma. So even if you see on the CT a large intraparenchymal hematoma and the patient is herniating, maybe he would have preserved a few brainstem reflexes. However, because of the superimposed let's say sodium that is only 125 or that is 180, or because your BUN is now through the roof. Maybe that is why you're basically exacerbating their coma or their loss of brainstem reflexes, and basically the patient was not brain dead, and 5% of their coma is explained by something else. So that needs to be excluded. So we have very clear, and now in the new guidelines, actually extremely well delineated prerequisites before you examine the patient. You have to have no confounders. So the patient needs to be warm. So that means that the temperature needs to be above 36. We'll go into even more details later. You need to be perfused to assess the brain perfectly. Like if the map is too low, obviously maybe there's a few brainstem reflexes that have disappeared, but once you re-elevate the blood pressure, they're gonna reappear, and the patient is obviously alive if he has brainstem reflexes. So you need to be warm, you need to be perfused, meaning a map above 75 and a systolic above 100. You need to be not sedated. That seems trivial. I mean, that seems obvious, but never enter the room and declare somebody brain dead without checking with the nurse and checking in the computer that no benzos, no propofol, and no paralytics were given recently. No toxic or metabolic derangement need to be present, and no, obviously, CNS depressant. The most depressant CNS depressant agent, as you know, is the barbiturates. So we in severe TBI often use pentobarb, and the guidelines are telling us now that you need to have basically proof that the level is extremely low, nearly nil, basically, so that you can declare your patient. So make sure that no barbiturate, no benzos, no propofol was given to the patient. And about the toxic metabolic derangement, we'll go into more details what the guidelines are. Unfortunately, now have clarified too much, because now there's set ranges that you need to meet. Even if the authors of the guidelines said that it was very arbitrary, and actually the first author and the senior author was opposed to publishing those ranges, because now we have an elevation in the cases in which we need to resort to an ancillary test. So you've established they have a huge injury to their brain, and yes, notoriously, that has been reported in the literature as a possible progression towards brain death. I've now come to the bedside and I want to examine my patient, but first I need to look in the chart, making sure that there's no confounders and all the requisites are met. My patient is warm, perfused, not sedated, no metabolic derangement, and yeah, no sedation was used recently. Then I can proceed with the exam from head to toe, or from cortex to medulla, I should say. So you start with the cortex, you pinch your patient everywhere, and you the same way you do it in a TBI exam, right? You pinch the nail beds, you do a sternal rub, a trapezius pinching, and you assess that your patient does not have any motoric responses that are coming from the cortex, or even coming from the brainstem. So flexor posturing, extensor posturing are both signs that would tell you that the brainstem is functioning, and therefore the patient is not dead, and you can stop right there. You can declare your patient alive and proceed with continuing neurocritical care or neurosurgical interventions, or discuss comfort measures, but the patient is alive if they have some posturing. So you've assessed the cortex and you've assessed the brain stem, at least for the movements in terms of posturing. Remember that also you need to pinch on the face, because what if even if they collapse in front of somebody and there was a cardiac arrest and there was no trauma, you may miss actually a C-spine injury. So technically, on every single patient that we need to declare brain dead, we need to have pain applied not only on the sternal rub and the pterygoid, the trapezius and the nail bed pressures on the four extremities, but you also need to apply pain on the face directly so that you bypass any potential C-spine injury. So pterygoid pressure or retromandibular pressure will trigger pain directly higher than a C1 potential C-spine injury. And you also do supraorbital pressure. So if in absence of that, I mean, if you stimulated the patient high enough and there's absence of motoric responses, then your patient is in the deep unresponsive coma. You can proceed to step 4. Step 4 is the brainstem clinical exam. So you start with the pupils. They need to be slightly dilated or mid-size. So it means more than 2 millimeters. They cannot be small. They cannot be 1 millimeter or pinpoint, because if you really wiped out your brainstem, you should have actually at least mid-size, if not dilated pupils. And also pinpoint should make you go back to your prerequisites and triple check the fact that there was no opiates that was given to the patient. So if they are mid-size or dilated and unreactive or non-reactive, sorry, in better English, non-reactive pupils mean that they are not contracting to light. Constricting to light, that means that the upper part of the brainstem is not functional. If you have pupillometry, you can use a pupillometer, and an NPI of 0 and a number of millimeters in the size more than 2 millimeters would suffice to say, yes, I've objectively measured that the pupillary reflex is absent. So once you're done with the pupils, then you do the corneals. The corneals are by touching the eyeball, and now in the new guidelines, they even tell you the only way to do that is first you can use the water flushes that they have next to the ventilator with those little pink little flushes, but because you can start with that during your normal coma exam, but during the declaration of brain death, you need to escalate the stimulus. You cannot use water, you cannot use a gauze. It has to be a Q-tip close to the sclera, at the edge of the sclera and the iris, and you slightly depress the eyeball. So you move the eyeball, but don't jiggle it, otherwise it's gonna move the palpebra, the eyelid. So you move a little bit, but without jiggling, you just depress a little bit the eyeball. That's a deep pressure, and that should trigger a blink. And if you don't observe a blink, neither the upper palpebra nor the inferior palpebra are moving into a closure. The corneal reflex is absent. Oculocephalogyric reflexes are doll's eyes. So you rock from side to side, maintaining the tube in the mouth, the head, and you should see the eyes veering back to the midline. That's actually not what dolls are doing. Dolls are actually with vertical eyelid movement, not the eyeballs, but historically, I guess, we call them doll's eyes. So it's rocking from side to side the head, and it should trigger the eyeballs to come back towards the midline. And if they don't, you don't, your vestibular pathways are disrupted, suggestive of the fact that the brainstem is wiped out by the injury and the herniation. And you, yeah.
Dr. Kapinos, what I just wanted to interject on the doll's eyes, just because I agree it's not a good terminology, and so I try to avoid using it. Should use, oculocephalic reflex if possible. Partly because old-fashioned dolls had the eyes painted on, and so actually the old-fashioned doll's eyes did not move when you moved the head, right? So it's like, so I think it's one of those situations where, to avoid confusion, it's just better to use, the actual oculocephalic reflex present or not present.
Exactly. And if you see me sometimes using OCGR, it's because I guess in France we call them oculocephalogyric. Gyric means you're rocking the head. So OCR in the nomenclature in America, yeah, is the proper terminology. Once you've tested that, basically, and it's absent, you need to do the same stimulus but deeper. So you see the recurrent theme is that first you should do a coma exam without thinking that your patient is dead, and it's perfectly fine to use water in the cornea to test if the patient, because if it's present, then you know your patient is alive. You don't even need to do the Q-tip. But for declaration of brain death, after the water on the cornea, you should use the Q-tip, and then after negative or an absent oculocephalogyric reflex, you should escalate to the caloric reflex, which is basically cold water in the ear canal that should go towards the tympanic membranes, that should stimulate the vestibular pathways even more strongly than your rocking from side to side of the head. So it's the same vestibular pathways. Why are we using both? It's because number one, if you have Doll's eyes, if you have your eyes rocking back towards the middle during your OCR testing, then you know your patient is alive, so you don't need to do the caloric. Why not just jumping to caloric? I just explained why, and why sometimes we're going to use a straight OVR, oculovestibular reflex, or caloric testing, and we're going to skip the OCR. The only reason to do that is when you have a C-spine injury or a skull base fracture involving the foramen magnum. Technically, by rocking the head from side to side, you could injure even more the spine, and therefore you cannot do it. So that's the only reason where you are or let's say, no, the second reason is also if they have an injury to their eyeball, like a burn, or they are enucleated, then you cannot do the OCR. But if they are enucleated, you cannot even do the caloric testing. Anyway, so you've done your OCR and it's negative. You've done then the cold water in each ear and it's negative. You don't see any nystagmus or any movement of the eyes. You know that the vestibular pathways in the brainstem are wiped out by the herniation process or ischemic process, whatever is destroying the brainstem. So then you continue down. You have the gag. So that is to be done not by mobilizing the ET tube, but by using the Yankauer or a tongue depressor, and you go to the back of the throat, and you should see a gagging reflex, which is like trying to vomit, or a grimace. Anything that is basically a motoric response to the stimulus of the pharynx should be proof that the cranial nerve 10 and 11 are working well, and therefore also the brainstem was also functioning. Therefore, the patient is alive. So Yankauer or tongue depressor, you don't see movement, then that continues to prove that so far the patient seems to be declarable for brain death. You continue to go down. After gag, it's the cough. You advance the suctioning device that is in line with your ET tube. You go all the way down to the carina and you press for the suctioning. If suctioning all the way down to the carina does not trigger a coughing reflex, that means that indeed the brainstem quite low now in the pons is not functioning. And then the last test is spontaneous breathing, which is both in my step number 4 and step number 5. So it's basically the same again. That's the third time that I'm telling you. You start with a mild stimulus, then you escalate to a stronger stimulus. I taught you that for the corneals and for the OCR, then caloric testing. Here it's the same. Basically, you should be first looking at the vent and seeing if the patient is over breathing the vent, and even better, if you are empowered to do so as an intensivist or a neuroclinician that is privileged to do brain depth testing, you should feel comfortable with the agreement of the ICU team and the respiratory therapist to just do a CPAP trial of 45 seconds. So if you put the ventilator on CPAP, you're basically telling the ventilator, don't generate the breath, let the patient initiate every breath and then support them. And you can even play with the trigger, 1.6 to 2 liters a minute, so that mild vibration, and don't touch the bed, by the way. You don't want any vibration that will mobilize the column of air in the ventilator and be a false trigger of the ventilator. And so if you observe that your patient is apneic on a CPAP trial, then you can proceed with a stronger stimulus of the medulla, which will be step 5, an apnea test. So don't call it a mini apnea test. It's just a passive observation on step 4 that you should not walk out of the room and say, okay, everything was negative, the brainstem are all gone, and I'm going to prepare and put so much in motion to do an apnea test when the guy is obviously breathing in front of you if you were to do a CPAP trial. So I always recommend that you do as an intensivist or a neuroclinician that is privileged in brain death. Do your own CPAP trial that's in the exam. You just need to observe, is my patient already obviously taking a breath within 45 seconds? It's not an apnea test because we're not even accumulating the CO2 yet. But a lot of patients, including one recently, can remain with a medullary function, and they remain right above brain death for a few days or week. The progression of the herniation sometimes does take time. So you're done, you've observed your patient, he seems to be apneic, at least with a normal CO2. Now the step 5 will be to prepare for an apnea test. So that will be witnessing if the patient takes a breath, not upon normal pH and normal CO2, but extra strong stimulus to the medulla, so that if there are remaining neurons in the medulla that are functioning, the patient should take a breath with a chest excursion or accessory muscle use, a little bit of a movement of the ribs and the chest cage. So to stimulate the medulla very strongly, you need to drop your pH from normal 735 to less than 730. And you need to, by doing so, you're doing it via an accumulation of CO2. So some old testing, we're actually giving CO2, but we don't have that technology here, carbogen that is delivered in the patient circulation. So what you do is basically you tell the ventilator to not support the patient, you turn it off. Actually, you don't put it on CPAP because the maximum time is only 45 seconds and the trigger would be too controversial. So it's better to just turn off your ventilator. You put it on, it's called bypass or standby, on standby mode. So you click standby and you're gonna accumulate the CO2, but you preserve the oxygen level. So you're gonna deliver with a nasocannula inside the ET tube 4 liters per minute maximum of oxygen to maintain the normal level of oxygen, but the CO2 should accumulate because of the apnea of your patient. And once the accumulation has been so strong, 20 points above the baseline, you're reaching above 60 of PaCO2. When you started with a normal range of CO2 between 35 and 45, and your pH went down to less than 730, now the CSF must be also very acidotic, and the medulla, if there's any residual neurons that are functioning, should make the patient take a breath. So your eyes are on the patient for 10 to 15 minutes, and it is your eyes looking at the chest excursion that is absent that declares the patient. It is not the ABG per se. So a misconception that a respiratory therapist and some residents have is that, oh, the ABG proved to me that it did not breathe because the CO2 rose 20 points and we're above 60 and the pH went down. No, some patients can be agonal breathing, one breath every minute, that will still accumulate CO2 super high, but if they took a breath, they're alive. So it's not the ABG per se that tells you that your patient is dead. It's you, the neuroclinician or intensivist, that is examining the patient with your own eyes during those 10 or 15 minutes of an apnea test during the proper stimulation. So that is why you cannot declare without the ABG results. But the ABG results are only telling you, yes, you were in the proper setting, you've stimulated the medulla enough, it was an extreme stimulus, and it is your eyes showing, seeing that there was no chest movement that is declaring the patient dead. There was no respiratory efforts during the proper stimulation of the medulla, therefore the medulla is completely dysfunctional. Therefore, it is the last caudal point of herniation and the patient is deemed to have no brain function. Moving on to the ancillary test. Here I'm just saying that you should really continue to be clinical, go from step 1 to step 2, step 3, step 4, step 5, and don't casually just rely on something else. Yes, it is true that neuroimaging is basically establishing the etiology, but don't replace your judgment. You need to read the HNP, and even sometimes if it's weird, like the patient was found down at home or at a party or in the garden outside, don't go by just the imaging. You need to really make sure that he was not found next to a needle of, then you need to dig for opiates or other medications that can mimic coma. When the requisites are not met, some people say, well, don't worry, anyway, I'm going to do evoked potentials and it's going to show that there's no cortical function, therefore my patient is dead. No, you cannot replace your due diligence to do a chart check, look yourself at the map above 75, the systolic above 100, the patient did not receive propofol, the sodium is normal, the BUN is normal. If the patient has liver failure, you need to check the ammonia. You need to do that due diligence of a chart check to make sure the requisites are met. Don't replace that by a brain death ancillary test like evoked potentials. For the exam, sometimes you will see a movement and you're like, is it cortical, is it the brainstem, or is it a spinal reflex? If you're unsure about it, ask another neuroclinician. So ideally a neurointensivist that trained in that, or a recently trained neurosurgeon is deemed to be an expert at all those movements. You guys deal with spinal cord injuries. You've seen also all those different spinal reflexes that can be sometimes exacerbated. So, but don't just jump, oh, I'm a young neurologist and I don't know if that movement is abnormal or not. I'm just gonna order an EEG and it's gonna answer that. The guidelines and Ilko Weidix and everybody have been really inculcating in all the neurointensivists that the proper way to do it is always try to remain clinical. You should hate resorting to an ancillary test. Same with the brainstem areflexia. You should try to really do a clinical exam. And even if today, let's say the patient has an AA gradient, well, that doesn't mean that tomorrow he's still going to have an AA gradient. So maybe you try diuretics, you try to fix whatever is going on so that you do a complete exam of the brainstem, including an apnea test. The apnea test is really the ultimate test that without it, you should really think twice about declaring somebody. And maybe at that time, really, if you tried 3 days in a row, the AA gradient doesn't go away, or the patient is too hypotensive, and you think the acidosis of an apnea test will kill your patient, they're gonna code on you. Then, of course, then you should at that time give up and then resort to an ancillary test. But try as hard as possible to do the gray pathway here, which is purely clinical and not resorting to an ancillary test. Another message that I'm sending and that others agree with is, oh, don't say, well, on step 2 anyway, I need to do an ancillary test, so I don't need to continue to be super thorough on my clinical exam. Anyway, what's going to declare the patient is a brain death ancillary test, which here is abbreviated as BDAT. That's not true. It's true. You should continue to go through your clinical exam. If one requisite is not met, let's say the hypernatremia cannot be fixed. I bombarded my patient with D5W for several days and I'm still at 161. And now with the new guidelines, they say if the sodium cannot be corrected, you need to resort to an ancillary test. You should still continue to do step 3, deep coma exam, step 4, brainstem areflexia, and step 5, the apnea test. Continue to do everything, and then you replace whatever elements of your clinical exam were missing on your clinical pathway with one ancillary test. But don't think, oh, don't worry, my brain death ancillary test is going to be used for step 2, and therefore I don't even need to do step 5. It's going to answer the question. No, you should always continue to be on the gray path, which is the clinical process of declaring somebody, and only when one element or several elements of your pathways need to be answered by an ancillary test. Yes, you're going to use an ancillary test, but continue to be diligent in your clinical pathway. Historically, though, there has been, like, especially in the pediatric world and in other countries, people were always saying, well, you do your clinical pathway, but you need to buttress your process. Because it's a neonate, we're going to use an EEG. Because we don't trust our apnea test, we're going to use a conventional angiogram or what have you. So they were using ancillary tests are buttressing tests or confirmatory tests. But in America, the guidelines have always been no, you need to be clinical. There's no buttressing, no confirmatory, no corroborating test. We only need to do the clinical exam, and only when one exam is absolutely not available, we use an ancillary test as a surrogate for that element. But the declaration of death is still clinical. I think that's it for this PowerPoint. I'll close it and I'll share the actual guidelines. But any questions so far?
Just to clarify, in that situation, so say you have a patient that's hypernatremic, and what's the upper limit that they allow now?
160.
160. So say it's 165.
Yeah.
And because they're hypernatremic, you're now going to be obligated to get a confirmatory test unless it corrects, right? So like, let's say for whatever reason it's not coming down. Would you still do an apnea test then, even though you still are going to get a confirmatory test? You would still do the apnea test, like you said. You still go through, finish everything, do the apnea test as long as it's going to be safe for the patient, and then do the confirmatory study, ancillary study.
Yes, exactly. So that's actually why, yeah, most authors of those new guidelines were opposed, but through the Delphi process, they had to publish that those ranges. So I asked them, like, at 161, I cannot declare the patient without an ancillary test, and they told me, unfortunately, yes. On the prior version of the guidelines, they were saying that it is in the eye of the declarer to consider if it is a confounder or not. So you could have said, this patient has herniation, a terrific a terrible like a herniation on the imaging. I know that it's not because of the sodium that they are brain dead. I know it's not a confounder. You could have declared before, but now look at this sentence that I'm highlighting here. If metabolic deranges are unable to be adequately corrected, but the neurological exam and apnea tests are consistent with brain death, the clinician must perform an ancillary test to address basically this abnormal sodium of 161. It sounds ridiculous, but they force that upon us. So they put in the, here it says, there's no scientific rationale to define specific laboratory results. And the prior guidelines had basically referred to another publication about those proposed ranges. And but now they have it, and so it says 130 to 160. The BUN needs to be less than 75. The ammonia needs to be below 75. If you have liver failure, you need to test that. The calcium needs to be normal. The potassium needs to be normal too, and they put specific ranges. So first you need to try to address it. It says, I hope you can see my screen. Clinicians must ensure that metabolic derangement, intoxication, and metabolic medications that depress the CNS are excluded, adequately corrected, or eliminated before evaluating the patient as clinically appropriate. So you could still use the as clinically appropriate to apply maybe to the metabolic derangement, and you could say, well, I've seen the patient already with an exam compatible with brain death before the sodium shot up. But frankly, then that doesn't jive with that second sentence where it's the actual recommendation statement 12b, sorry, where it says if metabolic derangements are unable to be adequately corrected, you must perform an ancillary test. So, but the other source of thing that we need to cover is the skull-base fractures. So there, I think there is a little bit more leeway to still say that because in two sentences it says that it is basically as clinically deemed a confounder. So we could declare with a skull-base fracture if it's a linear one, small one, and we think it is not confounding the exam. Or let's say a perime's subarachnoid hemorrhage, and you're like, you know what, I don't think it's gonna really disrupt the cranial nerve that much. My exam is deemed unconfounded. You can still declare. But here for the metabolic derangement, Yeah, so I asked Dr. Greer, like, do I really have to do an ancillary test for a sodium that is high? He told me yes, he was against. He didn't want to publish those arbitrary ranges, basically, but yeah, it got in, and so you could say as clinically appropriate. Therefore, you can declare ADIC 161, but then somebody's gonna say no, you're violating that sentence where it says the clinician must perform an ancillary test. Um, so yeah, maybe let's go linearly. I'll try to go fast. Those new guidelines are both for pediatrics and adult into a single guideline. That's wonderful. But the drawback was that indeed pediatricians are forced upon almost like a second exam. They go over even the details of how to do it with ECMO, what do you do with TTM, and what do you do when you have a primary bleed that is infratentorial. So it's great that now we have one place with one single guideline rather than referring to too many different publications. But it was a modified Delphi, so not everybody got happy what they wanted in that publication. They go over the qualifications and the specific considerations a lot, so that's wonderful. Just to tell you, yeah, by the way, it was the American Academy of Neurology, but also the Society of Critical Care Medicine, the Pediatric Neurology Association, and there was also a CNS, for neurosurgeons, the Congress of Neurological Surgeons, as well as the Child Neurological Society. So both abbreviations have endorsed, both societies with the same abbreviations have endorsed this publication, this guideline. The thing that is really great also is that they finally transformed ethicists really had to address the fact that we know there's a few brain dead patients that have now carried pregnancy and stay alive for decades. It is not also all neurological functions or all brain functions, because neuroendocrine functions can be maintained and you're still declared brain dead. So they tweaked a few words. Instead of irreversible, they said now the word permanent. Which means that it will not resume spontaneously, and we deem it futile medically to try to reverse it. So medical interventions will not be used to attempt restoration of that function. So you understand that it is better, for instance, for ICP. You don't need to place an ICP monitor or to continue osmotherapy forever to try to address that. So the word permanent was better than irreversible, because it means it will not resume spontaneously and no more medical interventions will be done. So you try osmotherapy first, and then once the patient progresses to brain death, you don't need to continue treating to have a normal ICP at the time of your declaration. It is not the cessation of all functions with an S anymore of the entire brain, because that was a misnomer. As we said, neuroendocrine function can be preserved. So it's now renamed as a permanent loss of function, singular, of the brain as a whole, not the entire brain, but the brain as a whole is a better terminology. So people who really push that new terminology, as I said, were ethicists and um, uh, some may say, I mean, lawyers may say, well, it is not in accord with the UGA, right? The original publication that was in the law in the United States, because they still use the word irreversible loss of functions, plural, of the entire brain. But now neurologists have pushed forward these tweaking in the language, which to me, I'm perfectly aligned with that. Ariane Lewis was leading those ethical revisions of the terminology here, and we all agree that the better terminology now is this: not irreversible but permanent loss of function as a single function of the brain as a whole, meaning that the brain does not communicate to all those different centers to maintain consciousness and maintain your person as a whole. At the end of the day, it is a medical and legal definition that the person is gone, therefore the brain as a whole does not function, even if a few areas of your brain would still be functioning. And that goes along with what Ilko Weidix at the Mayo had done 20 years ago, which was serial pathology evaluation, right? The coroner at the Mayo Clinic did examine the brain and the brain stem, basically, of all the brain dead patients that were declared by the neurointensivist at the Mayo under ILCO's WIDIC's guidance, and they published that actually the majority of the brain structures were preserved. It is not a mushy tissue in 99% of the volume of the brain that is the corollary on pathology of brain death. No, you can have actually quite preserved areas of the brain, which goes along with the fact that we've had notoriously SPECT or CT angiograms telling you that there's preservation of some tissue in the brain. So that is why the clinical exam needs to be paramount, and what you use, not an ancillary test, because if you do a cadaveric examination of all those brain dead patients, you will see even the brain stem doesn't have to be completely gone and ischemic with ischemic changes on pathology. So the new definition is permanent loss of function of the brain as a whole, and it will be coma, brainstem areflexia on the exam, and then stimulation of the medulla with a hypercarbic test that will really show you that the medulla is gone. In that order, you will be able to declare your patient dead. So it goes over who can do it. The PAs and trainees are technically not deemed adequately privileged to do that. However, they say if you're an APP working in a state where you are an independent practitioner and there's a scarcity of neurologists and intensivists in that hospital, then of course your hospital can privilege you as a senior APP, and you'd better probably go online and do the training by the Neurocritical Care Society, not to be sued or be in the news for one of your patients that you declared brain dead woke up subsequently. So they go over those qualifications. Even here, I've said to Dr. Hickman and Dr. Farey that indeed, I don't think any just average neurologist or average neurosurgeon, just by their training in residency, should be deemed competent. Here, the guidelines are telling you you need to demonstrate your competencies, and they suggest that you use the online training by the Neurocritical Care Society that goes over those details. Even myself, I've learned a great deal by going to learn from Dr. Greer in Boston to know a few details on the proper way of declaring brain death. It is not trivial. You don't want to be, as I said, in the news with your patient that retrieved a few brainstem reflexes or even worse, consciousness, which has never been reported, by the way, but after declaring somebody dead. So we went over the requisites. So we said about the systolic, it's above 100. The MAP has to be above 75. About hypothermia, they talked about also the fact that if you've been cooled or you dropped because of your cardiac arrest and a few hours in the cold outside, you dropped your temperature below 35.5. Not only you need to be above 36, but we need to wait now 24 hours after you reach 36 to declare. So that happened quite a few times where I had to educate the MICU. No. Even if the patient is now 36.2, you cannot declare the patient. We need to wait. So we look back into, did they reach less than 35.5? If that was the case, then we need to wait 24 hours after reaching again 36.0 to declare the patient. It makes sense, right? I mean, they were so cold that you probably stun the brain stem. Don't examine them as soon as they reach 36.0 or 36.1. Frankly, maybe the neurons will resume their physiologic activity, and the patient will retrieve a breath and a cough if you wait long enough. So that is why they put that criteria. We talked about 100, 75, or the 5th percentile for the pediatric cases. We talked about the fact that they've basically said there's no rationale to define what is a normal range, but they give it to you in the table that I've sent to many of you, and I'll send it again on our chat today. For toxicology, you need to have a alcohol level low, and I created in our own guidelines a little bit more clarity here, because actually it doesn't say exactly the difference between propofol versus Keppra. Basically, they say that Keppra can sedate you a little bit, and yes, it would make sense to try to check a level, but sometimes when the level takes too long, for instance, barbiturates takes too long to come back, you should wait basically 5 half-lives. We talked about that. The clinical exam already went over it. The children, it's just that for neonates, we need to replace our brainstem reflexes with the two reflexes are present in neonates. But basically, everything else has been the same for many decades. You know how to do the OCR, how to do the caloric test. One point I should cover though is, yeah, the skull base fracture. So let me show you what is highlighted here. If I do search skull base or skull fractures. So they start their paragraphs by giving you a rationale. So they say that basically accurate assessment of the OCR and OVR can be impeded by anophthalmia, severe orbital scleral edema, or chemosis, skull fracture, cervical spine fracture, or ruptured tympanic membrane. And then they say accurate assessment of the corneal can be impeded also by that, and accurate assessment of the gag and cough can be impeded by the cervical, the C-spine injury. So if you cannot be assessed safely, you need to do an ancillary test. So here, there's a leeway that you could say, I'm a neurosurgeon. I know that a skull base fracture that is linear, non-displaced, although so small, even if it's in the temporal lobe, temporal bone, it is not impeding my exam. So you could say that you use that statement here and that you deemed it to be basically safe, and you don't need to perform an ancillary test. And furthermore, it says here that there's a later sentence where it says it's not because you have a skull base fracture that you have to use an ancillary test. So here it's basically up to your judgment. But in my personal opinion, I would say that if it's the low part of your temporal bone that is close enough to where the cranial nerve 8 is running, or you have a thick subarachnoid perimease, frankly, the cranial nerve 8 is maybe dysfunctional, and therefore the caloric testing that I'm gonna do and the OCR is not gonna be valid. So I err on the side of actually ordering, when there is a skull base fracture that I deem quite significant, an ancillary test. So I've asked around, and it's true that since those new guidelines are talking about that, and they say if you cannot assess safely, you must perform an ancillary test. Unfortunately, now we're using more ancillary tests for those skull base fractures or craniectomized patient, and you feel like maybe there was a disruption of the cranial nerve 8. Frankly, even concussion, sometimes we know that the cranial nerve 8 is not functioning well. There's tinnitus, there's like even deafness that have been reported. So it does make sense that you want to you want a confirmatory test, or say that I don't trust my OCR and my OVR, and I use an ancillary test. That being said, I'm not sending the message because of I'm not sending the message to all the trauma community. As soon as you have a skull base fracture, you have to use an ancillary test because of that second sentence. Let's say if I search fracture, there's another one. It says the presence of an open fontanelle skull fracture, skull defect, does not preclude performance of a complete clinical assessment and apnea test, but can affect ancillary testing too. Yeah. Injuries such as fractures of the C-spine skull base preclude an accurate assessment of any components of the neurological exam. And then you need to use an ancillary test. But it says also, yeah, here is the counterpoint. In patients who meet all clinical criteria for brain death, clinicians should not perform an ancillary test solely based on the presence of an open fontanelle, a skull fracture, or a skull defect, or an EVD. Yeah, it does make sense. So you see, like, you can use both statements to your benefit. So I think one day there was Dr. Batty and Dr. Hickman, you decided that it was fine declaring the patient without an ancillary test because the skull base fracture was non-displaced and there was not a thick subract there. And I think yeah, that's perfectly aligned with this statement 27F. But if, let's say, a less expert person was on the case and they said, well, I don't feel comfortable with a temporal bone fracture, declaring the patient I was an ancillary test, then they would be aligned with the prior statement that I showed you here, saying that those type of injuries are making the accurate assessment quite challenged. And brain death ancillary testing, I don't have time to cover it on its own, but basically, just briefly, EEG was removed, CTA was removed, so it is only a conventional angiogram, a SPECT or a nuclear scan with at least four views, and dynamic is recommended. And by the way, with not HMPAO, but by CIS-8. Those are the ways to declare somebody brain dead, as well as TCDs, which is the only bedside procedure, although there are some nuclear options, by the way, that can be done at the bedside. And there's even now in Spain a portable nuclear scan where people are starting to use it for brain death declaration on unstable patient. But for us at Elmhurst, I will say currently, unfortunately, it's only a conventional angiogram. TCDs, unless they have an open skull, or if they're pediatric. So even at 17 years of age, unfortunately, I cannot use TCDs to declare our patients, which makes no sense, and I will try to modify that. But in any case, yeah, TCDs, conventional angiogram, and SPECT are the only way to do an ancillary test nowadays. Any questions? So I'll send, there's a PDF, not of this exactly, but of a concise version, and it's tables, and it gives you also the ranges, the sodium 130 to 160, the BUN less than 75, etc. So I'll send the PDF of the tables of those guidelines that are a concise way of looking at it. But yes, they greatly enhance the clarity on the clinical exam, the proper way of being privileged to do the declaration. But unfortunately, they created a little bit of an increase in us resorting to ancillary tests because of those metabolic ranges that are quite artificial, that are quite debatable. And also those ambivalent statements that make trauma actually sometimes use a little bit more ancillary tests to declare the patient. But always the message should be, go back to your clinical exam. Don't just say, oh, today there's hypoxemia in that patient or is hypotensive, therefore I'm just gonna order an ancillary test. That is wrong. You should try to fix it and continue on the path that I presented in my PowerPoint that is in gray, which is the clinical pathway. Don't jump onto an ancillary test just to be addressing something that you could have fixed.
Great. Thank you, Dr. Kapinos. It's very thorough. If there's no questions, I think we will adjourn. Thanks, everyone. Sure.